between donors with a DRI from 0 to less than 2, which made up about 90% of the donor pool, and high, or donors with a DRI of greater than or equal to 2, and that made up about 10% of the donor pool. This is a Kaplan-Meier plot of patient survival by donor risk index, and what you see is the yellow triangles represent survival of a recipient who received a low DRI organ with a 3-year survival of 70%, while the blue squares represent survival of a recipient who received a high DRI organ and had a 3-year survival of around 62%. Using Cox regression modeling, we developed hypothetical patient survival profiles. And what you see here is the upper curve represents survival of a recipient who had the best combination of donor and recipient characteristics, while the lower curve represents survival of a recipient who had the worst combination of donor and recipient characteristics. And what you see is if you put a marginal graft and a marginal recipient, you get very bad results very quickly. This next slide is also hypothetical patient profiles. And what we see here is that if you pair a moderately high DRI with a more suitable recipient, you get very good survival profile, which is very similar to optimal donor and recipient characteristics. Therefore, the aim of this study was to evaluate the cost effectiveness of an organ allocation scheme using high and low DRI donors compared to a scheme using only low DRI donors. To do this, we looked at 2 databases between February 2002 and June 2007. We looked at the UNOS database and our Vanderbilt database. Then we developed a Markov model to simulate patient survival in 2 organ allocation schemes, a low and high DRI donor allocation scheme and a low DRI only donor scheme. We then estimated quality adjusted life expectancy and total lifetime costs with this model. We adopted the societal perspective and looked at the impact of the intervention on society as a whole. Plausible ranges for all model parameter values were based on UNOS data, VUMC data, and systematic literature review. Our transition probabilities determined movement through different health states over a 10-year horizon. We derived cost data from published studies of Medicare costs looking at indirect and direct costs of transplantation. However, we do not consider immunosuppressive costs. Our estimates of efficacy or utility were based on pooled results of published studies. We chose to look at the quality, or quality adjusted life year, which accounts for an individual's preference for the quality of life in a given health state, with 0 equal to death and 1 perfect health. The study population in base case scenario was based on a recipient who was 45 years of age, had a diagnosis of hepatitis C, and had a MELD of 22. This slide demonstrates our Markov states or health states. So a person starts off on the, with end-stage liver disease. They either remain on the wait list, transplant and survive, require retransplantation, or they die. And they're moved through these health states on a yearly basis over a 10-year horizon. This is the complete Markov model in all its complexity, and then a more simplified schematic. So again, patients end-stage liver disease are either, in our model, put through a scheme which uses both low and high DRI organs, and then move through the transition states, or a low DRI only,